National Neonatology Forum on this World Liver Day, which is celebrated on 19th of April every year. And this year, the theme is Food is Medicine. This year, the theme is Food is Medicine. And NNF has decided to get two very special people who specialize in hepatology and gastroenterology, especially pediatric hepatology and gastroenterology. Two of our topics today are neonatal liver failure and approach to management of neonatal cholestasis. These two topics are really very important so far as newborn care is concerned, and all those who take care of newborns in the intensive care settings, they are very well versed, and they are very much face this kind of clinical scenario in their everyday clinical practice. So I hope that this will be very useful for all the audience about today's speakers. And our first speaker is Dr. Aarti Pavaria, who is MD Pediatrics, followed by she did her DM in Pediatric Hepatology and Gastroenterology from Institute of Liver and Biliary Sciences, New Delhi, completed in 2018. And currently she is working as Chief of Pediatric Hepatologist and Transplant Physician in SAR HN Reliance Foundation Hospital and Research Center in Mumbai. So I hope this will be a very highly knowledge sharing session among all. So thank you. I invite now Dr. Aarti to take over the session.
Thank you very much, sir, for the brief introduction. And today, I'm thankful to the National Neonatology Forum that they have given us an opportunity. And as a pediatric hepatologist, of course, our population begins at birth. And everybody knows that when we say 1,000 years of life are important, as important is the maternal and neonatal interaction of what comes out in the newborn as a liver. So it is a very precious opportunity to start talking about liver even when the child is born at that point. So I'll briefly go through this, and I'll try to conceptually put a perspective which should be a perspective which every neonatologist and every pediatrician should know, because the right channelization is the most important when children present. So when we say acute liver failure, it is a specific definition. It is, in the next slide, I'll tell you what is neonatal liver failure, but acute liver failure by definition is when we have a liver failure in which we have an INR more than 1.5 in the presence of hepatic encephalopathy, or an INR more than 2, irrespective of encephalopathy, along with evidence that it is only an acute liver injury and there is no known evidence of chronic liver disease. This is the standard definition of acute liver failure in children. However, the newborns differ from this. And why the newborns differ, and we must know, is because the first time that the newborn can ever present with any symptoms is at birth. That means anything which presents at birth would be considered acute, even though there has been some injury in that liver which is going on in the fetal life, because we have a concept of fetal neonatal continuum of the liver disease. So that means even if some liver disease was present in the fetal period as a part of the etiology of that liver, and it has presented obviously to us at birth, it may have some chronicity. It may be going on from mid-gestation, but it may only present in the newborn period. And hence, all the neonatal liver failures will include children who have even cirrhosis. This is a very, very major thing. We cannot say that this is not acute liver failure because it has cirrhosis. All cirrhosis will be included in children in the definition of neonatal acute liver failure, unlike in the pediatric acute liver failure. So there is a neonatal liver failure and there's a pediatric liver failure. Second, the INR definition will change. Many of the term newborns have an INR up to 2, which is normal, and a lot of preterm will have INR up to more than 2 also, which is normal. And hence, the cutoff for neonatal liver failure will be INR of 3 and not INR of 2 or 1.5. The next thing important is in children itself, in the pediatric age group, hepatic encephalopathy is very difficult to pick. So of course, in newborn period, it is impossible to pick. And hence, hepatic encephalopathy is not a part of the definition. The fourth important thing, as would mention, is of course the etiologies. We know that we are here. We have started to talk about what all can damage a newborn liver, and in the subsequent slide, I will go upon all these things. Which is the most common is the neonatal hemochromatosis, or the new name, which is gestational alloimmune disease, and I will tell the relation between them. In the newborn period, when I say viral, I don't mean hepatitis A, B, C, D, or E. I mean those viruses which can affect the liver. However, they are not the usual causes of infections in older children. So they remain the ones which are either transplacentally or during birth being transmitted to the child. HLH remains an important etiology. Mitochondrial remains etiology specific, and of course, some metabolic liver disease. So, from this, it is very clear that we are not talking about in the subsequent seminar about any child who's more than 1 month of age. We are strictly talking about neonatal liver failure, which by definition is till 28 days of life. That they present with liver failure till 28 days of life. And we look at the different studies which came up, it is very common that hemochromatosis, the neonatal hemochromatosis, it is an important part. Of course, many will remain indeterminate, especially the one viruses which are very uncommon, which may not be picked up. But however, it is important to say that as the time has gone, the survival of with native liver of neonatal liver failures have improved from a very, very dismal to a good amount of survival. And as you would say, again, in this picture, metabolic neonatal hemochromatosis, viral and others would come. But of course, the neonatal hemochromatosis, which will be from after the seminar, which we will be calling as gestational alloimmune disease, and we'll know what is neonatal hemochromatosis is the most important. So we go to the others also where they're specifically taken only neonate. Again, we realize that the NH group is the major one. So we cannot forget whenever we say neonatal hemochromatosis, neonatal liver failure, everything about neonatal hemochromatosis and GALD we must know, and what are the other causes. As you see now, even in the best of the centers in the world where pediatric hepatology is practiced, there is a high degree of mortality which is associated. But at the same time, over the years, there has been improvement in relative improvement in the medical care. This study, this is a table which summarizes all the different studies which have shown. And I would not want to go in deep into the numbers, but it is important that we are again and again talking about 4 to 5 etiologies. Now, when I start that the liver disease in the perinatal period are important because you have to understand and then find what is the important thing. So in the perinatal period, which includes a neonatal liver failure, we will have some congenital infections which will are transmitted during the birth as HSV while the passage through the birth canal, or maybe some other infections which are transplacentally transferred like the CMV and others. Gestational alloimmune disease, which is an appropriate term specifically used by a pathophysiological mechanism. In the older years, everything was synonymously used, which is called neonatal hemochromatosis. The other remains viral hepatitis and some metabolic liver diseases. When I call the gestational alloimmune disease, which is GALD, we understand that GALD and NH are not synonymous. Neonatal hemochromatosis is a single disease etiology. This is a reason why that happens. Neonatal hemochromatosis basically means that the newborn liver will have a lot of liver, will have a lot of iron. At the same time, it will have a lot of extrahepatic iron. And important thing is that this is not a smaller version of hereditary hemochromatosis in the adult. So please, there is no need of sending mutations for hereditary hemochromatosis. No need of checking the parents for those mutations because this is not just a neonatal counterpart of it. Where is the relation between neonatal hemochromatosis and hereditary hemochromatosis is just that the liver has a lot of iron. Similarly, extrahepatic tissues also have a lot of iron with the exception of reticuloendothelial system. But otherwise, they do not share a common pathophysiology, and hence we have started to use the term gestational alloimmune disease. Gestational alloimmune disease is the most common disease causing neonatal liver failure. However, we say neonatal hemochromatosis is a pathophysiology which happens in a lot of liver diseases, and the most common of it is GALD. So when I go to the pathophysiology, it says that because of sensitization and initial transfer of fetal soluble fetal liver peptide of the protein, the mother got sensitized. The mother produced an IgG, and the IgG came back to the fetus through the placenta. When it came, it started hitting on the new hepatocytes which were being formed. That means there has been an injury to a developing hepatocyte. They have not even completely developed. Into a developing hepatocyte, we are having an injury, and then, of course, a cascade of immune system, including the complement activation, a lot of activation natural killer cells, and the subsequent issues. So when the fetal liver undergoes an injury, the liver tries to regenerate. It tries to regenerate, but what happens is the cells, which were the mesenchymal stem cells, rather than making absolute sheets of hepatocytes, they aberrantly develop. When they aberrantly develop, it leads to increased tubulogenesis and a lot of fibrosis. And this is typically which we will see in the liver biopsies of these patients. This is the only liver failure where we see increased tubulogenesis, a lot of tubules being formed because there are bile duct also. It's a haphazard growth. It's just survival. It's a fight to survive. So they're just making anything they can make, and a lot of fibrosis. No other acute liver failure in the newborn period or the pediatric age group forms tubules and lays down that massive fibrosis as happens into this. They all have a lot of acute hepatic necrosis. The parenchyma will just shatter down. There'll be a collapse of the framework, but it does not give time for tubulogenesis. It happens only in galled diseases. So what happens when the liver is undergoing a lot of injuries? Secondary to this injury, the iron maintenance mechanisms of the liver are overwhelmed of the new developing liver, and hence iron starts to get deposited. So iron started to get deposited secondary to a liver insult. Not that iron was deposited excessively first and then the liver injury happens. So this is the basic difference. If we are able to understand them, the rest of the seminar becomes extremely easy. That in GALD, the liver injury happened first, and because the liver got injured, it was not able to handle iron, and hence the iron deposition became more in the liver and extrahepatic tissues. Whereas in hereditary hemochromatosis, in the adult counterpart, body has a specific reason or a gene mutation to say that I'm not able to handle routine iron. So I started depositing more iron in the liver, and hence the liver got injured. So here in the neonatal hemochromatosis or the GALD, the injury to the developing liver happened first, and then what happens is the of iron deposition. So this is exactly what I said, that a lot of fetal liver protein goes into the metabolic circulation through the syncytial trophoblast and comes back in sensitized with IgG, and then hits onto the fetal liver, and hence is the role of IVIG. So I would say that GALD is a congenital and familial. However, it is not genetic. There is no gene mutation that happens, and it is not a hereditary disease. However, because it is familial and it has a immune mechanism to it, it has a very high rate of recurrence in the future pregnancy. And of course, it is a prototype of a fetal liver disease that extends into the newborn period and causing liver failure. And hence we say, please do not confuse this with the hereditary hemochromatosis of the adults. This is exactly what you would see in the liver biopsies of GALD, which are going through a spectrum of neonatal hemochromatosis, a lot of pseudo-SNI formation in the parenchyma, a lot of parenchymal fibrosis, and a lot of iron extra deposition. Complex mechanisms, a lot of things involved, including hepcidin, ferroportin, transferrin, and what all systems get involved. And finally, the end result is that the transport of iron is overwhelmed, and there is excessive deposition of iron in the liver and also in the extrahepatic tissues. And how do we then identify having to have this concept, that we cannot afford to not understand this concept when we are dealing with the newborn liver? And then we will see the rest. The rest is very easy. So if you have understood it, the rest is extremely easy. So again and again, I would say, when we have a neonatal liver failure, look for the fetal losses previously. Obviously, this was a fetus who was affected in the fetal period right from mid gestation, and hence they will definitely have IUGR, they will definitely have hydroamnios, and because of the insult, they may have a premature birth as well. This liver failure develops within hours and not much later, because the liver was already much damaged before even the child was born. And hence, because the severity of the liver injury was much, there was a lot of hypoglycemia, marked coagulopathy that we would see, a lot of low protein, lot of coagulopathy, a lot of edema, a lot of oliguria. And hence, these are the features of end stage, very severe liver failures that we develop. If we have anything like this, we cannot afford to not understand GALD or neonatal hemochromatosis. Where are the extrahepatic tissues they form? They can have in pancreas, heart, adrenals, thyroid, the mucosal or the minor salivary glands, and hence is the diagnosis from the lip biopsy. Specifically, the reticuloendothelial system is spared, and this is a part of the mechanism. Even in the adult hemochromatosis, the reticuloendothelial system is spared. That means the way iron overload happens and the aberrations happen in that entire system, which is beyond the scope of this webinar, we understand that there is a relative sparing of the reticuloendothelial system. However, apart from that, we will see extra features. There is, because it was a fetal disease, there happens by the mechanisms of angiotensinogen deficiency, which leads to renal dysgenesis. So if we have to identify what renal parameters are part of this, so renal dysgenesis is a part of this. So sometimes, because we know now the pathophysiology, if in the antenatal scans we see that the liver appears cirrhotic, and there is in the fetal MRI, if we see there in the T2 signal, there are low signal intensity in the liver. That means they appear much more darker than the spleen. And these are the features which can be picked up. Now, each one of these findings, which we see in neonatal liver failure and what it differentiates from other causes, is important to understand. Always in neonatal hemochromatosis, the AST, ALT are disproportionately low to the degree of injury. And why does that happen? Is because the normal liver was not even allowed to develop. Your hepatocyte should at least develop to throw off AST, ALT into the bloodstream to race. But in this, it never was normally developed, and is the reason that the AST, ALT are very low. They will usually have high alpha fetoprotein because alpha fetoprotein is a marker of liver regeneration as well. So there was a lot of regeneration, including there could be regenerative nodules in the liver in these cases, and hence it will be high. Ferritin is high because the iron hemostasis has been disordered. However, we usually do not find levels more than 7,000. When we have features more than 7,000 ferritin, we usually start saying that this is not GALT and this may be something else like an HLH. Because we have what we have is sometimes we get the liver tissue, and when we get that liver tissue, because of the pathophysiology that I explained, there is a lot of complement deposition there, and hence the complement 5b to 9 complex gets deposited in the liver. And if we do a liver biopsy for any reason, we will find the increased tubulogenesis, fibrosis, a lot of iron staining, and a lot of significant fibrosis. Along with that, we may find it. But if you ask me, is GALT the only disease in which we find this? No, there are many other neonatal liver diseases. Because everything has a pathophysiology related to this, they will also develop this. It has been found that the GALT neonatal hemochromatosis has a persistent patency of ductus venosus, and hence splenomegaly may not develop. So especially you will have a newborn with a significant cirrhotic liver with no spleen sometimes. So you should not say that this is not cirrhosis or why is the spleen not there. The spleen is not there because of the patency of the ductus venosus, it escaped splenomegaly, and hence these things are very important. I already spoke about C59 and I would go further. So whenever we suspect a GAL, it has to be a liver disease which was antenatally present or present immediately after birth when it came to the medical care. It is responsible for unexplained cases of stillbirth and newborn death. The diagnosis is by demonstration of extrahepatic cirrhosis, which includes a T2 MRI where they look much more darker than the spleen, or you do a biopsy, a lip biopsy, and it will show you. This is specifically the two arrows that you see. See, look at the spleen. These dark areas in the liver are much, much darker than the spleen, and that deposits, that shows much more iron deposition. This is a lip biopsy, which is usually done, and when you do a histology of this, they will say extrahepatic cirrhosis. So, in a child who was at IUGR, who had an oligohydramnios, even though if it is the first child of the mother, and we do not know the um, previous pregnancy history, by a hard liver, a cirrhotic liver, very severe coagulopathy, low transaminitis, but a very low albumin, a significant coagulopathy, a sick child with a presentation similar to this, it should take us another 24 to 48 hours to identify this and go ahead with the biopsy and do it. So, but This is still the most common, and hence this we cannot forget in neonatal liver failure. An important part of GALT also is that we have IVIG, we have double volume exchange transfusion, which is a part of its treatment, and hence we should start it early. Now, how to differentiate this from all other causes of neonatal liver failure? Very easy. There are very limited number of infections that can cause the herpes simplex virus, very high transaminitis. Acyclovir, if you have a liver disease, liver failure, very high transaminitis, please start acyclovir as soon as possible until you rule it out. CMV. CMV is the majority of the times IgM comes positive and some other things come positive, but please believe it causes much more cholestatic and a slow smoldering cholestatic rather than a neonatal liver failure. But we have to be sure that we know the definition of neonatal liver failure. Another group, which is the enteroviruses, are the ones which are postnatally acquired, and a maternal history of a URI infection or a diarrhea just preceding the illness in the child is considered to be related to enterovirus if it is not anything else. In the same category as enterovirus comes the ecoviruses, and there have been cases reported. If you look at other viruses like the parvovirus, though they may interplay with other chronic liver diseases and come as bone marrow involvement, however, in the neonatal liver failure, there have been no case reported for them. How do we diagnose them? Just not by IgM. If we think that a virus has caused a liver failure, the demonstration on a PCR, either in the blood or in the stool or in the urine, depending on where they're excreted, is very important. Unless we have a very high STLT where we are putting acyclovir and saving the child, the others, which no specific etiologies, do not usually do well. And CMV is an exception to this. CMV children, usually, if you treat them, they will. First of all, they usually will not present as liver failure, but even if they're present, and if you treat them, they will be slightly better. Now, this table, I'm sure all of us have been seeing many times. And an important part is that once we understand everything about this GALT, the rest of the things are very easy to understand. HLH, all of us working in the ICU, we know how HLH behaves. They are sick children. They are very high ferritins. They have an associated features. We get into the diagnosis by their criteria of splenomegaly, fever, cytopenias, soluble IL-25, and many other things. But however, viral infections, HSV, few others we must know. HLH, we all know. This, the whole story we know. Why they will have a low ASTLT, why they will have a high INR in gestational alloimmune disease. The fourth component is mitochondrial hepatopathy. Now, mitochondrial hepatopathy can present anytime. They can present acute liver failure in the newborn or in the pediatric or even later. They may present as cirrhosis, they may present as many other things. But the point is, there are very few mitochondrial hepatopathies, which includes only less than 5% of the total neonatal liver failure that they present. Specific things like the deoxyguanase deficiency, which specifically presents in the newborn period, is an exception. But when you have a mitochondrial hepatopathy, you will definitely not have features of cirrhotic liver. You will have liver failure, acute liver failure. You may have cardiomyopathy. You may have other organ involvement in the form of CNS and others. And it presents with the metabolic distress in the form of high lactates, significant acidosis, and many other features. So it is easy to document. One, you know whether I'm dealing with GALD NH, what I have to do, start an IVIG, once I run to the diagnosis very fast, do a double volume exchange transfusion followed by an IVIG, and you should be saving many of these children, if not all. And they do improve gradually. They will not show you drastic changes. They will improve. You have to take care of any other chronic liver disease as you see because they're cirrhotics. So they will go gradually, but many of them will improve. 30 to 40% will improve and even will regress the fibrosis. So if we are able to identify GALT, the HSV viral infection, knowing that is not just IgM and IgG, which are going to be important, and definitely keeping our eyes open to HLH, we should be doing justice to them. This is, again, I'm pretty sure with after this we would know that of course it is a disease where bilirubin is going to be very high, transplant may will be normal, HSV will have very high AST/ALT, and the rest we all know. It is not a rocket science. It becomes very easy. Again, this paper, in closing the webinar, I would say that whenever we have a child with neonatal liver failure, look at the clinical scenario. If it is suspicious, you start treating, send a biopsy, send an MRI, followed by making a final diagnosis and doing exchange transfusion, again followed by an IVIG. If you think the clinical scenario is not suspicious of NH, and there is some other diagnosis, you consider other ways to find it out. The second thing is that in case, and I would say that this has been taken from one of the articles which took the previous INR. Again, I would say we take an INR of 3. We do not take an INR of 2. However, if we feel that there is a significant moderate to severe elevation of liver enzymes, it is not like a NH prototype. You start acyclovir and then gradually see whether it is actually HSV or some HLH or some other causes and do the needful. Try to transplants in neonatal age group have their own challenges, not feasible. And the other thing is, what if it is GALD? If we miss that, the future children of that mother is also going to get affected. To try to get to the diagnosis of this present child, even though it is the child with best of your medical care may not survive, but getting to the diagnosis in this neonatal liver failure is very, very important. So summarizing, the outcome of neonatal acute liver failure is significantly poor. However, it has improved in the recent years. If only we know the viral infections which may cause it, everything GALD has to be taken in consideration in appropriate surroundings, and they still remain the most common etiologies of acute liver failure in newborn period. The metabolic and genetics are the other new causes. If you ask me between galactosemia, tyrosinemia, and hereditary fructose intolerance, which are the metabolic liver disease, tyrosinemia comes first. Some of them may present in the first month. Second would be galactosemia. Some may present by 3 to 4 weeks of age, but not immediately at birth. Neither will tyrosinemia present immediately at birth, but yes, by the 3rd or the 4th week. Hereditary fructose intolerance may present in case you were giving syrups or a formula feed to the child and not only breast milk, which was containing sucrose or fructose, and hence we should not be running after their diagnosis. Everything and anything should be explainable by broadly classifying them at identification. A significantly elevated amino transferases and presentation is a specific indication to viral infection. However, coagulopathy with low amino transferases are indicator of a GALD and NH. A simple LFT is going to tell us. And despite medical therapy, native liver survival, which was 0, is still low, but it is not 0. Second, there is the incidence of liver transplantation, neonatal liver failure has been now reduced because they have been able to salvage some of these children without that. Thank you very much. I would be happy to answer any questions.
That's a wonderful, very detailed webinar, Dr. Aarti. Congratulations for that.
Thank you, sir.
So, Dr. Arjit?
I think he must have
Okay,
left
Dr.
because he was
Arjit.
traveling.
Okay. So, Dr. Sanjay?
I think we'll take the next topic and then we'll take
Yes, let's take the next topic and
questions
then, yes, okay.
yeah. So let me invite our next speaker, Dr. Kalpana Panda. She is going to talk on approach and management of neonatal cholestasis. She has done her MD Pediatrics and DM Pediatric Hepatology, and she is Associate Professor, Division of Pediatrics, Gastroenterology and Hepatology, and Department of Pediatrics, IMS, SVM Medical College and Hospital, Bhubaneswar. So welcome, Dr. Kalpana, and you can start your presentation.
Thank you, sir. Is the screen visible to everybody?
Yes.
Okay. Okay. Good afternoon, everyone. So first, I would like to express my sincere thanks to NNF for giving me this opportunity to deliver this talk on neonatal cholestasis on the occasion of World Liver Day. Neonatal cholestasis is one of the most common gastrointestinal problem encountered during neonatal period, which, if not diagnosed and managed in a timely manner, sometimes led to devastating outcomes. So, jaundice is common during newborn period. Most of the times, it is a physiological jaundice or unconjugated hyperbilirubinemia due to this ABO or RH incompatibility, whereas neonatal cholestasis refers to conjugated hyperbilirubinemia or increase in the direct fraction of the total bilirubin. So, if any newborn who is present, who is having jaundice and having this dark or high colored urine that is staining the diaper, then you should always keep a strong suspicion of this neonatal cholestasis. So what is conjugated hyperbilirubinemia? It is defined as the direct bilirubin more than 1 milligram per deciliter if the total bilirubin is less than 5, or direct bilirubin more than 20% if the total bilirubin is more than 5 milligram per deciliter. One thing I want to emphasize here is that this new conjugated hyperbilirubinemia, it is pathological irrespective of the age of the neonate. That is, since day one it is pathological, unlike that of your unconjugated hyperbilirubinemia. So this neonatal cholestasis, it is not an etiological diagnosis. It is just a syndromic diagnosis. Like if you are having fever, then you have to look for the cause. So if this newborn is having this neonatal cholestasis, then you have to look for the causes. Neonatal cholestasis is just a syndromic diagnosis. There are at least 30 to 40 different causes which can present as neonatal cholestasis or conjugated hyperbilirubinemia. So broadly speaking, the causes of neonatal cholestasis could be divided into two, that is extrahepatic or intrahepatic. Extrahepatic means if there is some defect or some obstruction in the extrahepatic biliary system, that is your common bile duct or hepatic duct, like that. The most common, we all know, it is biliary atresia, where there is atresia of this common hepatic duct or common bile duct. And the second one is your choledochal cyst, where there is dilatation of the common bile duct. These are the two most common causes. Other causes are there, like your spontaneous perforation of bile duct, inspissated bile duct syndrome, or there is some congenital stricture of the bile duct, etc. Then comes the intrahepatic causes. In intrahepatic or otherwise called hepatocellular causes, there is some genetic or acquired defect in the hepatocellular formation or excretion of the bile. So the common ones are your genetic transporter defects like progressive familial intrahepatic cholestasis, various forms of metabolic liver diseases, or paucity of bile ducts, some infective causes like your congenital CMV infection, etc. And another one is your this multifactorial or TPN related cholestasis, which usually we encounter in preterm babies with a stromal-neonatal period. So I will come to it in later. So these are the broad classification of etiological causes of neonatal cholestasis. This term idiopathic neonatal hepatitis, it has now become obsolete. As you can see in this 1970 series, or more than 50%, that is almost 65% of the cases has been labeled as idiopathic neonatal hepatitis. However, this portion has now shrunk. In 2000 series, this portion is only 15%. And in this latest series from India, this series from India IL-based, the portion of this idiopathic cause is only 10%. Thanks to the wider availability of genetic testing and advanced treatment, advanced diagnostic modalities, we are now able to diagnose more than 90% cases of this neonatal cholestasis. So that this term idiopathic neonatal hepatitis is not very much not applicable in today's scenario. So the basic question, how to approach a case of neonatal cholestasis. For this, first you have to establish that the newborn or the neonate is having neonatal cholestasis. Can you establish it clinically? Yes. If the mother is complaining that this jaundice baby is having diaper staining or high colored like mustard color urine which is staining the diapers, then definitely suspect this neonatal cholestasis and start further workup without delay. So I will give the example of 4 cases, starting with this case. This is a 56 days old male baby, full-term delivery with a good birth weight of 3.2 kg. He presented with progressively increasing jaundice started from day 20 of life, along with ecolic or pale stools. There was no perinatal issues. Antenatal and perinatal period was totally uneventful. There was no history of any seizures, altered sensorium, abdominal distension, or any kind of developmental abnormality. However, the mother complained that the child is having epistaxis along with ecchymotic patches for 3 to 4 days. INR was deranged. However, it got corrected after giving vitamin K. On examination, the weight and height percentiles of the baby was between 75 to 90 percentile. There was icterus. However, there was no peripheral stigmata of any chronic liver disease. On per abdomen examination, liver was 4 centimeter form with a spleen of 3 centimeter. However, there was no ascites. These are the investigations of the baby. As you can see, there was progressively increasing jaundice starting from total bilirubin of 7 and direct component of 4.6 to 13 total bilirubin and direct component of 9.7. There was mild transaminitis, and the point here I want to note is that the digit is high. It was 342 at day 50 of life. Albumin was normal. INR was initially deranged but got corrected after vitamin K from 5.7 to 1.2 post vitamin K, and CBC was normal. He came with already with an ultrasound abdomen. There was liver and enlarged liver and spleen with a small gallbladder of 0.9 centimeter. CBD was not visualized, and they have reported it that triangular cord sign was positive. So the syndromic diagnosis for this baby is he is a case of neonatal cholestasis with pale stools, with good birth weight, and now also growing well with hepatosplenomegaly with a high. So with this syndromic diagnosis, the most probable etiological diagnosis, as we all know, is a case of biliary atresia. So the clues in this patient is that pale stool, the good birth weight, as well as good growth after birth with high digity, and obviously ultrasound showing a triangular cord sign with a small gallbladder and non-visualization of CBD. The most probable etiology is biliary atresia. So, whenever you are dealing with such a child, that is neonatal cholestasis with pale stools, the two most common DDs are biliary atresia and choledochal cyst, which usually can be differentiated on the basis of ultrasound, at least for screening purpose. In biliary atresia, the CBD is not visualized, whereas in choledochal cyst, the CBD is usually dilated. Now coming to case 2, this is a 26-day-old male, a preterm delivery with a very low birth weight of 1200 gram. He presented with jaundice since day 10 of life, which is progressively increasing, along with a fluctuating stool. The stool is more towards pigmented, but sometimes he is also passing pale stool. There is prolonged NICU stay history with a stormy perinatal period. He was on CPAP, received multiple exchange transfusions for neonatal hyperbilirubinemia. He also had a history of neonatal sepsis. However, there was no history of any seizure, altered sensorium, or abdominal distension now, and he is now gaining weight and accepting feed well. On examination, the weight and length percentiles are between 50 to 75th percentile. There is mild icterus. There is no peripheral stigmata of any chronic liver disease. There is a soft liver of 2 centimeter, no spleen, and no ascites. These are his investigations. That bilirubin is increasing progressively. However, there is mild transaminitis. GGT is slightly high, that is 124 and 128. And albumin and INR are absolutely normal. CBC, complete blood count is also normal. Ultrasound was done. It showed only mild hepatomegaly. GP was visualized around 2.8 centimeter. CBD is also visualized, and it is normal. There is no ascites. So, the syndromic diagnosis in this case is a case of neonatal cholestasis with fluctuating stool, more pigmented than pale, with a stormy neonatal period, with mild hepatomegaly with preserved synthetic function. So, in this case, the probable etiological diagnosis is multifactorial. Most probable etiological diagnosis is multifactorial. Yes, we have to work up for biliary atresia. We have to rule out this, but the most common etiology in this case is multifactorial. So whenever we are dealing with a neonatal cholestasis, the child, the first thing we have to do is look for the stool color for 3 consecutive days to decide whether it is a pale stool or a pigmented stool. So this is a protocol-based approach to deal with neonatal cholestasis babies. So on the basis of stool color, if it is a echolic stool or a fluctuating stool color, the most common differences would be biliary atresia followed by choledochal cyst and multifactorial. These are the 3 most common etiologies. Whereas if it is a pigmented stool, then you have to again look for the other clinical signs and history. If it is a well child or a sick child. Here sick child means sick by means of sick child. I want to tell that whether the child is having any features of decompensation or infection. Decompensation meaning if the child is having abdominal distension, ascites, anasarca, or features of hepatic encephalopathy in the form of irritability, refusal to feeding, vomiting, sepsis-like picture, etc. For infections also, similar thing. He's not irritable, not accepting feeds, or having this sepsis, hypothermia or hyperthermia. So if it is a sick child, then the diagnostic algorithm is separate. And if it is a well child, then the common things we should consider, we have to rule out is hypothyroidism or trichomes, because hypothyroidism, Down syndrome, or other trichomes, they can present with neonatal cholestasis sometimes. So this is a stool color card. Many Asian countries like Taiwan, South Korea, Japan, China, they have already started this yellow alert campaign where these stool color cards have been incorporated in the in your well baby cards or immunization cards, where the mother can look for the stool color of the baby and report it as whether normal or abnormal. These last row, these are the normal stool colors, whereas this first 2 rows, these are abnormal stool colors. This yellow alert or this stool color campaign is basically for screening for basically a primary care level screening for biliary atresia. So these are the healthy stools. These are the suspicious stools. We should also try to incorporate this stool color card chart in our well baby cards or immunization cards. Now coming to case scenario 3, this is a 1.5-month-old female on exclusive breastfeeding. He was term delivery, birth weight of 2.3 kg. She presented with jaundice starting from day 10 of life, with pigmented stools, with failure to gain weight and progressive abdominal distension for past 3 weeks. Now he presented with history of a sepsis-like picture like fever, lethargy, refusal to feed for 3 days. There was no history of any seizure, altered sensorium, diarrhea, vomiting, or extrahepatic involvement. However, there was a family history of 3rd degree consanguinity, 1 abortion at 6 months of age, 1 SIP death at day 23 of life, cause is not known. Rest antenatal, natal, and postnatal history were uneventful. On examination, the child was lethargic. There was mild pallor, significant icterus, bilateral pedal edema, or there was also bilateral cataract on ocular examination. On per abdomen examination, there was a firm liver of 3 cm with a span of 7 cm, spleen of 2 cm, and there was gross ascites. So these are her investigations. There was anemia, hemoglobin was 6.4, thrombocytopenia with a deranged INR which was not get corrected even after 2 doses of vitamin K. INR was 2.9. There was this total bilirubin was 6.7 with a direct component of 3.4, and albumin was significantly low, that is 1.8. So to summarize, this is a case of neonatal cholestasis with pigmented stools in a sick child with decompensation, that is ascites, with sepsis-like picture, with failure to thrive, with consanguinity, with sibling death, with deranged synthetic functions, that is coagulopathy, uncorrectable coagulopathy with hypoalbuminemia. So with this background, we must think of a metabolic liver disease. So what are the red flag signs for a metabolic liver disease, which can present with like a neonatal cholestasis like picture? So these are the red flag signs for a metabolic liver disease. If there is history of consanguinity, multiple abortions, previous sibling deaths, or history of failure to thrive, diarrhea, vomiting, sepsis-like pictures, or on liver function test is significant synthetic dysfunction, that is hypoalbuminemia and uncorrectable coagulopathy, which is disproportionate to the jaundice. There is hypoglycemia, lactic acidosis, hyperammonemia. These are the telltale or red flag signs for a metabolic liver disease. So again, coming back to our flowchart, if the child is having decompensation, basically these are the cases of neonatal liver failure, which Aarti ma'am has already described. We should consider the possibility of this metabolic liver disease like galactosemia, tyrosinemia, this neonatal hemochromatosis. These are the most common causes. In the patient I have already described, she was a case of galactosemia. And if we are suspecting infections, the most common infections are congenital cytomegalovirus infections. Now coming to the case 4, this is a 6-month-old male infant who presented with jaundice since day 10 of life, which is progressively increasing. And now he is also having pruritus, significant pruritus and itching for past 2 months. Birth weight was normal, it was 3 kg. Perinatal period was uneventful. However, the mother is now complaining of steatorrhea, that is greasy, foul-smelling stools for past 3 to 4 months. And there was also history of epistaxis and multiple ecchymotic patches over the thigh. The stool was pigmented. There was no history of any seizures, altered sensorium or developmental delay or abdominal distension or irritability. Antenatal history was significant. The mother gave that she is having this pruritus in the last trimester of pregnancy, which got subsided after delivery of the child. Family history was normal. There was no consanguinity, no sib death or no miscarriage. On examination, there was mild pallor, mild icterus. However, there was conjunctival gerosis, white spots were present, and 2 ecchymotic patches were present on the thigh. On per abdomen examination, liver was 4 centimeter. It was soft in consistency with a span of 6 centimeters. There was a 3 centimeter spleen. However, there was no ascites. These are his investigations. Total bilirubin was 4.5 with a direct component of 2.5. Mild transaminitis. GGT was normal. It was 21. Albumin was normal, 3.7. INR was deranged, 4.2, but it got corrected after vitamin K. And CBC, there is mild anemia. Hemoglobin was 8.8. However, platelet count was normal. So, the syndromic diagnosis for this baby is a case of neonatal cholestasis with pigmented stools, with pruritus, with signs of head-soluble vitamin deficiency, vitamin A and vitamin K deficiency, with steatorrhea, with hepatosplenomegaly. So, the most probable etiological diagnosis in this case is a case of intrahepatic cholestasis, most probably because of some genetic transporter defects like PFIC. So if the child is having any neonatal cholestasis child, if he is having pigmented stool but not having features of this decompensation or in an infection, then if he or she is having features of like this vitamin fat soluble vitamin deficiency, pruritus or steatorrhea, you can consider the possibility of this genetic transporter defect or PFIC. Here I want to tell one thing, that these compartments are not watertight compartments. Like PFIC can also present like neonatal liver failure. There are some types of PFIC like PFIC type 4, PFIC type 2. They can have this neonatal liver failure like presentation. This is basically just a protocol based approach. This is a simplified approach. But to reach the final diagnosis, yes, we have to take the help of this genetic sequencing, etc. So how to investigate this child? So first, if you are dealing with a neonatal cholestasis baby, the first thing is to do is check for 3 consecutive stool colors, then to do a complete LFT. the liver function test, which includes your GGT with PT-INR. That is the most important part, because in many of the centers, this liver function test, GGT was not included, INR was not included. So you have to ask for a complete liver function test. After that, if the child is having pale stool or fluctuating stool color with a high GGT, consider the possibility of biliary atresia or choledochal cyst and go for an ultrasound abdomen. Here one thing, you have to do this ultrasound at least after 4 hours of fasting, which sometimes becomes difficult in small newborns, but 4-hour fasting is mandatory. If there is dilated CBT, you will think of choledochal cyst. If there is atretic gallbladder or pseudo gallbladder or triangular cord sign is positive, the CBT is not visualized, then think of the possibility of biliary atresia. Then you have to go for a liver biopsy. So many of the times, many people ask me, what is the role of HIDA? Is there any role of HIDA scan in diagnosis of biliary atresia? So the thing is that HIDA scan has a very limited value in biliary atresia diagnosis. On the basis of HIDA scan, you cannot establish the diagnosis of biliary atresia. You can only rule out biliary atresia if the this extrahepatic biliary duct is patent. That means if the dye comes down from liver to intestine. So if there is intestinal pressure uptake is present, you can rule out biliary atresia, but you can never establish the diagnosis of biliary atresia on the basis of HIDA scan. So it is better not to waste time on HIDA scan, because sometimes these newborns, these biliary atresia infants, they present late, and you are already wasting time 3 to 5 days for this phenobarbital priming and etc. for HIDA scan. Where every day counts. In case of biliary atresia, every day counts, because it is a surgical emergency. After 60 days of life, if you operate biliary atresia child, the success rate drastically decreases. So there is no point of going for this HIDA scan. If you are suspecting on the basis of pale stool, high GGT and ultrasound findings, directly go for a liver biopsy. Liver biopsy has a 90 to 95% accuracy for diagnosis of biliary atresia. It also has a prognostic role in patients of biliary atresia. If there is significant fibrosis on liver biopsy, then you can predict the outcome even after Kasai surgery, whether it is a good outcome, whether it is a poor outcome, and you can also rule out other causes of neonatal cholestasis. So if you are suspecting biliary atresia, always go for liver biopsy without further delay. Now, if the child is having pigmented stool and it is a sick child, that means the child is having decompensation, ascites, or hepatic encephalopathy, or features of infection, then you have to go for this metabolic screening, first line metabolic screening, followed by second line metabolic screening and septic screening. So what are these? So these are the first line metabolic screening. You have to do a fasting blood sugar, urine, NGRS. NGRS means non-glucose reducing substance. This is a screening test for galactosemia. Then alpha fetoprotein for tyrosinemia. Then arterial blood gas analysis to look for the lactate. If the lactate is very high, think of the possibility of mitochondrial hepatopathy, or in some cases of neonatal liver failure also the lactate is high. Then serum ferritin for this neonatal hemochromatosis. And after these first steps, on the basis of this first step results, you can go for second line screening. This I want to emphasize on this NGRS. This is a very basic test. We can do this on bedside. We just have to add urine 1 ml to 5 ml of Benedict's reagent, which is easily available in any biochemistry lab, and then to look for the color changes. It is a negative. This is a negative test. This is a positive test. If you are getting such a orange color, then always always consider the possibility of galactosemia, and start the baby on your galactose free, that is your zero lac or any other lactose free diet. And one precaution before this test, to get a false negative result, the child must be on exclusively breastfeeding or on a lactose or galactose based diet. Then the second line screening, on the basis of the first line test, you can go for a GALT assay. before you should not give any blood transfusion before GALT assay, because the result gets then the result becomes dubious then. And then urinary succinyl acetone for diagnosis of this tyrosinemia. Then other tests like lactate by pyruvate ratio for your mitochondrial hepatopathy. Then plasma TMS, urine GCMS for many organic aciduria or aminoacidopathies. So these are the second line tests. And the last and the definitive test, yes, we all know it is a exome sequencing. But the thing with exome sequencing is that it takes time. It at least takes 3 to 4 weeks. So these screening tests helps us to reach at least a close differential diagnosis, because galactosemia, if you start on a galactose-free diet, then you can save the life of the baby. For similar thing for tyrosinemia. For tyrosinemia, you can start the child on nitisinone, etc. So this screening test, they are very helpful, because genetic test, it takes time. Now, if this pigmented stool, the child is having pigmented stool, but without any features of this decompensation, etc., that means it is a well baby. Then do a thyroid function test, rule out hypothyroidism. And if the jaundice is persisting or progressing, then go for a liver biopsy, because there are so many causes like your PFICs, bile acid synthetic defects, Alagille syndrome, sometimes cases of your hereditary fructose intolerance, storage disease like your Gaucher's disease, Niemann-Pick's disease. They can also present with neonatal cholestasis or infantile cholestasis like that. So liver biopsy would be definitely helpful in these cases. So this is the protocol-based approach to a case of neonatal cholestasis. To summarize, I want to emphasize on these points. So first, conjugated hyperbilirubinemia at any age of neonatal period is pathological. A protocol-based approach in every neonatal cholestasis case is must to reach a specific diagnosis. The stool color card charts should be implemented by primary care physicians or pediatricians for early detection of biliary atresia cases. Stool color observation of consecutive stool color for 3 days along with LFT with a GGT is the first step in investigation for a neonatal cholestasis baby. Biliary atresia, it is a surgical emergency where every day counts. Whereas in case of metabolic liver diseases, it is a medical emergency where every hour counts. So in neonatal cholestasis patients, the most important thing is early referral, so that a prompt diagnosis could be made and a better outcome could be achieved. Thank you. I would be happy to take if there are any questions.
So thank you, Dr. Kalpana, for such a wonderful approach to neonatal cholestasis. So now we can take questions from the audience. If there are any questions, they can put them in the chat box.
Hello.
Yes, Dr. Amit.
Oh, yes, sir. Sir, your comments to this excellent talk. Case scenario based neonatal cholestasis, which was wonderfully explained. It was amazing to listen to and learn. You never stop learning, and
Yes.
so we never stop learning over there. So, your comments on this, sir?
Yeah, so she has made this difficult topic very simple. So depending on the color of the stool, with the stool color charts, we can diagnose these babies in early days itself. And as he said, during the in the biliary atresia, every day counts. So the diagnosis of biliary atresia can make as early as possible, so that surgical intervention can be done, and further damage to the liver can be prevented. And she has covered almost everything, and we face lots of time in surgical babies with neonatal cholestasis. And these metabolic conditions are very rare, but we see many of the time with neonates having E. coli sepsis and cataract. So we should suspect in these babies galactosemia. So,
Yes, sir.
yeah, so excellent presentation by both the speakers. Thank you very much, NNF, for organizing this wonderful seminar for today's Liver Day. So thank you, Dr. Amit.
Thank you, sir. Thank you. And ma'am, I had one query. Um, the workup for cholestasis, as you would have seen, is turns out to be very costly. Even if we don't reach up to the stage of whole exome sequencing, but most of the tests like workup for galactosemia, alpha 180, and CMV. So, is there any cheaper way or place where we can get the whole battery of tests done? And liver biopsy becomes an issue. Most of the people don't do it, and big institutes, there the waiting line and getting a OPD appointment is very difficult. So, go on, say, doing a liver biopsy, can it be done at peripheral center by somebody? And
Yes, sir, I agree, sir. Some of these tests are actually costly. But as I have already said that we are suspecting metabolic liver disease, sir. So, sir, we should do this basic metabolic screening. It is not very costly, sir. That is, I have already explained this NGRS. We can do it on bedside. And if it is coming positive, we can send the GALT assay, sir. GALT assay is hardly costing, sir, 2,000 or 3,000 rupees. It is not that costly. Yes, urine for succinyl acetone, it is being done in specific centers only. So yes, this tyrosinemia diagnosing tyrosinemia sometimes becomes difficult. And for neonatal hemochromatosis also, sir, the ferritin, it is not costing very much, sir.
not very costly.
So,
Yeah.
sir, yes, sir, on the basis of this, sir, first line screening, we can establish the most common causes for this, at least for this neonatal liver failure or neonatal cholestasis with deranged synthetic function or metabolic liver diseases, sir. But for rarer diagnosis, yes, we have to go for exome sequencing, sir. That is costly. And coming to the liver biopsy part, sir, sir, if there is no coagulopathy, then liver biopsy is almost safe on the, at least on the hands of an experienced radiologist, sir. We use it to do on the ultrasound guided, sir, by a radiologist only, sir. So if the INR is not deranged, then it is not a big issue, like for our biliary atresia babies. But for metabolic liver diseases, we cannot go for a liver biopsy because yes, there is uncorrectable coagulopathy, there is significant ascites. We cannot go for a liver biopsy, sir. So the most common indication for liver biopsy in a neonatal cholestasis child is, sir, biliary atresia. So yes, in biliary atresia babies, if they are not decompensated, like means if they are presenting within 1 month, 2 months, or 3 months age, we can easily go for a liver biopsy, sir. We can do with mild sedation without any need for ICU setup or anything like that. We could do it on a daycare basis, sir. So yes, we can do liver biopsy is not a big issue, sir. If the INR is not deranged or there is not ascites is not there, sir.
Okay, okay, ma'am. Thank you.
There is
And in liver
one
failure,
question.
yes, sir. Yes, sir. Yes, sir.
There is one question by the participant. What could be the cause of cholestasis with low GGT?
Yes. Sir, the low GGT cholestasis, you have to look for other symptoms, sir. So, like if the jaundice is persisting, like from neonatal cholestasis to it has become now an infantile cholestasis, jaundice is persisting like 6 months, 8 months, your jaundice is persisting. There is history of this pruritus, steatorrhea, or fat soluble vitamin deficiency. The first thing should come to your mind is your PFIC type 2, or sometimes PFIC type 1 also, sir. So these are the common conditions, sir. For low GGT cholestasis. And sir, sir, sometimes your this hypothyroidism, they can also present with low GGT cholestasis. But the most common symptom with low GGT cholestasis, you cannot tell with just with low GGT cholestasis. You have to look for other symptoms as well, sir.
If it is associated with hepatosplenomegaly, basically
Uh,
what we think is cholestasis. If low GGT, then it is hepatitis. If high GGT, then it is obstructive. And so then we start into workup for, but this is a simplified pediatrician approach towards
Yes, sir.
cholestasis.
Yes, sir. Sir, I have already told, sir, there is no such term for idiopathic neonatal hepatitis now, sir. It has become obsolete, sir. We have to work
Absolutely.
up, sir. If there is hepatosplenomegaly, that means the child is having at least some kind of genetic transporter defect, sir, with low GGT cholestasis. And also you have to look for pruritus and etc., sir. But
If
uh,
such a baby has IG and CMV positive, then is that diagnostic, or we have to go for PCR definitely to prove?
Sir, CMV, IgM itself has no role during the newborn period, sir, because it could very well be a
4 month
maternal
old,
antibody.
4 month old. It's a 4 month old child.
Sir, 4-month-old child, if there is no other features which are suggestive of congenital CMV infection, like like your weight is not very bad, he's growing well, or there is no other stigmata of your congenital CMV infection, then we have to go for a liver biopsy, sir. Without doing a liver biopsy on the basis of only urine CMV PCR or CMV IgM, we cannot just give the diagnosis of CMV hepatitis and start ganciclovir, because many of the children turned out to be cases of PFIC, sir. So we have to do for a liver biopsy, we have to do genetic testing, and on liver biopsy, we can always stain for the CMV, sir. But without doing all these things, this CMV hepatitis, because many of cases I am getting, ma'am must also be getting, they are being treated as this CMV hepatitis and turning out to be cases of PFIC, sir. So we have to
Okay,
go for, sir, liver biopsy.
I get that.
I would put a word here, sir, with the forums
Yes,
like the Neonatology, National Neonatology Forum, where, of course, the ongoing academic excellence and the way the newborns would be treated. They were treated 10 years back, now with lower mortality. Your preterms have been doing very well. Very sick small children have been doing very well. This is also an area where probably if we can collaborate in sense of an early second opinion. Hepatologists will not be present everywhere. Even if they are present, depending on the institution that they work, there would be some logistic issues this side or that side, be it terms of patient, be it terms of the costing, or be it terms of anything. But I believe, a early second opinion, even through a video consulting for a pediatric hepatologist, would lower down the differential diagnosis at your level, so that whatever money has to be used, that can be channelized in the right way. And
definitely.
as in the previous times also, you would have seen, the country doesn't need to really put money in everything which is non-salvageable, but we have to make sure we make early diagnosis of which can be salvageable. So
Yes,
that becomes a very important thing, that I don't think anybody has a problem in having a second opinion. And now with the post-corona, the video consulting that happens, the interpretation of even a simple LFT is so different when seen by an hepatologist, that we are not even ever only looking at GGT. You give us the entire thing with the history, with the LFT, with an INR, with the differential would be made, and then the funds can be channelized to what is needful and what is not needful. So if I
absolutely.
don't think that it requires a urine GCMS or a blood TMS, why waste money in that? So I think
Definitely.
that will
We
change the
should
outcome when
collaborate
we
in
have
that,
identified.
subspecialty collaboration is
It has
definitely
to,
required,
and
and
with everything in good intent to the patient, it is learning for us also. Each case is a learning for you. It's each case is a learning for us also.
definitely, madam. Definitely. Wonderful. So, Dr. Sanjay, after the two terrific talks, we can, there are no more questions in the chat box.
So
So,
there was only one question and she has already answered it.
yes, sir.
Yeah, so I think it was a very good presentation and take-home messages. Pediatricians should keep these tool color charts in their OPD files so that early diagnosis can be done. And to differentiate between hereditary hemocydrosis and GAL, there is first liver injury and then iron get deposited in neonatal hemochromatosis. So that was a wonderful talk by both the speakers. So I think we can now conclude this meeting if there are no further questions.
Yes, sir. Thank you. Thank you.
Thank you very much, sir. Thank you.
Thank you, dear
Thank you, sir.
speakers, for being
Thank you.
on time as well. Thank you, ma'am. Bye bye.
Thank you. Bye.